My topic is dealing with sexual dysfunction post-colorectal cancer surgery. I'm not a cancer surgery survivor. I'm a urological surgeon, but I've been working for a long time. So I'm most happy in the next 15 to 20 minutes to share with you my professional knowledge about the subject. I also have experience with real life cases, which I hope to share with you. And hopefully at the end of it, we all get some practical value in our daily life, whether it's in your life or a family member who is a cancer survivor or with your patients. I hope there'll be exchange of ideas. There'll be time for feedback at the end of my lecture or at the end of the entire 1 hour session, and hope every one of us will go back with improved knowledge. And lastly, I hope you will enjoy the session. I've been specifically told not only talk about male sexual dysfunction, but to include female sexual dysfunction as well. Now, how important is sex? Of course, after cancer therapy. Before cancer, we treat the cancer first. And based on this survey, in 5 continents, sex is very important in life. It's often thought that sex will stop after the age of 50, but actually there's no expiration date for sex. This article is from Medicine and Health, published in 2008. And you can look at this picture. Somebody sent to me recently of a very famous elderly man in Malaysia. And you can see, obviously, he's still very interested. For cancer survivors, after the cancer has been treated, the assessment and management of sexual dysfunction in men and women is very important. Colorectal surgery definitely affects sex. Why? Because the colon, the rectum, anus is very near to the pelvic organs, the prostate, bladder, penis in the male, and the uterus, cervix, and the vagina in the female. On top of that, we have the blood supply, we have the nerve supply to the pelvic organs, which runs very close to the colorectal area. The incidence of impotence or sexual dysfunction after rectal surgery ranges from 10 to 50%, as high as 50%. So it is a real problem. Yesterday, I met my university classmate, Dr. Samuel Tay, and I asked him what are his views of this topic. And he says that he always tells the patient when they consent for surgery that there is a risk of sexual dysfunction. However, in this particular study, which was published by the British Association of Urological Surgeons, that most colorectal surgeons do not have experience in treating sexual dysfunction following surgery. So my university classmate, who is now a colorectal surgeon, he tells me that, Clarence, my surgery is perfect. I try very hard to preserve the nerve, the blood vessel, if possible. Of course, if it's involved by cancer, it's more important to remove the cancer. That actually, after the surgery, damage can be caused by radiotherapy. There is also female sexual dysfunction after pelvic surgery. If the nerve and the structures in the pelvis responsible for female sexual function, example, the vagina, the cervix, and maybe the uterus, if they are denervated, if the blood supply is disrupted, of course, they also have sexual dysfunction after sex. Now, what is this sexual function? It's more than just having a child. Sex, you can divide into libido, ejaculation, orgasm, both in the male and female. And of course, in the male patients, we have the penis. And to have sexual function, the men have to have an erect, hard penis. And of course, we have to talk about testosterone, which is important, especially for men, but also in the woman to a certain extent. Now, there are very few female sexual dysfunction clinics. And when I was at Edinburgh long ago in 1989, 1990, they have a female sexual dysfunction clinic run by the psychiatric department. And when they analyze their demography of a few hundred women, the commonest female sexual dysfunction is impaired sexual interest. This is followed by orgasmic disorders, pain, example, vaginismus, and dyspareunia, form about 20% or 1/5 of the patients with female sexual dysfunction. And key to this problem is the problem of genital lubrication. I'm not an expert in female sexual dysfunction, but I can imagine that if you use a lubricant like KY jelly, many of these problems can be solved. Now I turn to male sexual dysfunction. The term is called erectile dysfunction nowadays, and is defined as inability to achieve or maintain erection for satisfactory sexual activity. Satisfactory, okay? So satisfaction depends on the couple. We seldom use the word impotence now, because impotence in Malay language would translate to mati pucuk. In other words, you are dead. So it's better to talk about erectile dysfunction rather than impotence. Now, how common is erectile dysfunction? I'm 67. So the chance of me having erectile dysfunction is probably about 60%. But then the erectile dysfunction that I may suffer from can be of various grades, can be complete, can be moderate, can be minimal. Of course, there's also a chance that even though you're elderly, you do not have erectile dysfunction. The next important thing is we talk about erection hardness, like blood pressure, blood glucose. Erection must be measurable. So it ranges from 1 to 4, where 4 is normal and 1 is larger but not hard. So I have an erection hardness model with me, but when we talk to the patient, sometimes we describe it in terms of the fruits. So in Malaysia, we have the kangkong. So if erection is like kangkong or like tofu, then it's very soft or grade 1. Whereas if it's like cucumber, then it is hard enough. The other important thing is the size of the organ. If the length and the girth has an important role to play as well, but we can discuss that another day. How common is erectile dysfunction or impotence in many countries? In Malaysia, Dr. Ismail Tambi, he did a study when he was in the Lembaga Perancang Keluarga, Malaysia, that there was a 16% chance of ED in Malaysia. Of course, in some countries, it may be higher. How often do people have sex? The frequency of sex in Malaysia per month on average is 3.1. And of course, some other countries where they are more hardworking in other sense, they may have a lesser chance, lesser frequency of sexual intercourse. When you see movies, you think that people have sex for hours, but in actual fact, the average duration of sexual intercourse in healthy people is about 9 to 10 minutes. 9 to 10 minutes. So this is important data to know when you treat normal people. I look at my patient load of erectile dysfunction way back in 2001, but I think things haven't changed so much. Maybe it's even worse. So the average age of patient is 54. So many young men also have erectile dysfunction, and they hold on to the problem for at least 1 year. In fact, some people hold on to the problem for 15 years. So every man with erectile dysfunction can be treated, but many Malaysian patients do not seek treatment. And when you look at the cohort of patients with erectile dysfunction, many of them also have associated medical conditions, hypertension, diabetes, psychological problems, low testosterone, heart problems. So all these problems are part and parcel of erectile dysfunction or sexual dysfunction. So there's a young man, he's a reflexologist. He come and see me, hoping that I could give him a tablet to cure him of his erectile dysfunction. But when I look at him, the nurses have already done a urine dipstick in the clinic, and his sugar was 4+, his blood sugar was 22. So I told him that you have to treat your diabetes as well. You've not treated the diabetes first. So you have to treat all this as part of the total wellness of the problem of erectile dysfunction. Of course, you cannot modify your age as we grow older, but there are other factors which you can modify. Your diet, exercise, reduce your body weight, reduce the smoking, and optimize your medications. All this can be done to improve your general health and therefore your sexual function as well. A colostomy by itself should not be associated with erectile dysfunction. But if you do an AP resection or anterior perineal resection, whereby the anus, the rectum is removed, then it can cause erectile dysfunction. But of course, if you do not remove the cancer, it's also dangerous as well. You can die from it. I gave credit to my daughter in London, who is a physician, because when I talked to her that I'm going to give this lecture, he said she got this photograph to me to show that actually young ladies or even old ladies who have colostomies, who have colorectal surgery, can make themselves sexually attractive, and they can empower themselves to feel sexy as well. Now, patients who go for surgery, especially colorectal surgery or pelvic surgery, they undergo all kinds of rehabilitation. But one important rehabilitation is penile rehabilitation after surgery. Because if you don't use the structure, it undergoes disuse atrophy. If you don't use it, you lose it. So you have to undergo early rehabilitation for sexual dysfunction after surgery. And this, of course, involves all the methods I'm going to tell you about in a short while. In coaching, we also do research. In the early days, we did research on sildenafil, which we published. And subsequently, we also did research on tadalafil, which again we published in 2004. So there are many medications you can take to improve the blood flow to the penis. The famous one is, of course, is Viagra or sildenafil. Most of these medications, you have to take it 1 hour before activity, and there are many types of them. The newest one is something that you can take just by put on top of your tongue, on top of your tongue. You don't have to drink water, so it's very discreet. It's just like a piece of paper. You don't have to carry a can of pills. Now, before we go away thinking that the treatment of erectile dysfunction or sexual dysfunction is just by treating that local organ, let me revise how we can have sex. First, it starts with the brain. The brain can have images, can think, can see, can smell, and the images, the nerve stimulation will go down the brainstem, go down to the spinal cord, go down to the pelvis. The pelvis apply to the penis, to the vagina, blood supply to the vagina. So actually, it is a pathway. It's a pathway. So the treatment is more than just that locality. And of course, we need testosterone. And all these pathways will give rise to erection, ejaculation, orgasm, and of course, female sexual function as well. And there are different pathways. Usually they're connected, but they may not be connected. The blood supply to the penis is most important. So when you have an erection, actually it's increase the blood supply to the penis. There's no bone in the penis. Now, if you take these medications, example, in this case, tadalafil or sildenafil, which is Viagra, you can improve your erection by more than 50%, but not 100%. Not 100%. You can improve your erection by up to 50% after surgery. In normal people, it may improve to by 90%, but after surgery, usually it's about 50%. So you have to have other means of treatment. The other minor problem to me is actually the adverse events from this medication. Sildenafil is the chemical name for Viagra. So these medications improve the blood flow to the penis as well as to other parts of the body. So you can have a headache, you can have flushing, you can have a blocked nose, you can have muscle pain, you can have some minor visual disturbance, or you can feel dizzy. So that's why some people say you have a good erection, but you're going to have sex with a headache. There's one very important precaution before you take these medications, and that is you should not be taking nitrates at the same time. Nitrates are given by the doctors, especially cardiologists, for chest pain. Chest pain. If you've taken a nitrate, your blood pressure can drop. You take a drug like Viagra, your blood pressure can also drop. And if the blood pressure drops below 80, you may have to be admitted for intravenous therapy, to support your blood pressure. In 1994, I published the findings of our first impotence clinic in Hospital Kuala Lumpur at that time. And the other therapy we use is injection, intracavernosal injection into the penis, as well as we give them vacuum pump devices, as well as penile prosthesis. So I'm going to talk a little bit about the other modalities of treatment of sexual dysfunction in the men. So this is the vacuum suction device. It's very limited suction, unlike the vacuum you use for cleaning the floor or your curtains. So we suck the blood into the penis. We put the rubber band at the base of the penis to hold the blood in the penis, and therefore they can maintain the erection for some time. This is especially useful for people with venous leak. The vein leaks out the blood from the penis. Another very important therapy for those who do not respond to medications is to inject the medication or the vasodilator directly into the penis. A common one that is used in Malaysia is called cover jet. So after about 10 minutes, you have a very good erection, and depending on the volume of cover jet you inject, the duration of the erection can be half an hour or up to 1 hour. And you only inject one side because there's communication between the right and the left tower of the penis. If the erection is more than 3 hours, then you have to see a doctor who often aspirate out the blood or even inject a vasoconstrictor to reduce the erection. So this is a very important treatment for patients with severe erectile dysfunction. Next, we talk about surgery. Now, for patients who do not respond to oral therapy or injection therapy, we can do surgery, and that is putting an implant into the penis. There are two types of implants. One is the type that we just put it permanently. The patient have an erection all the time, so that when they go to the swimming pool, the girls will be very impressed by what they see under his pants. For those who prefer to have a more discreet implant, it's called inflatable implant. There is a balloon containing fluid, and they can pump the fluid into the penis when they want to have an erection. Of course, there are pros and cons regarding the different devices. The next topic I want to touch on is that of testosterone. Now, testosterone is important for sex, especially the libido, even in females. But testosterone is also important for the brain, for cognitive function, for your mood, for the bone, and for the muscle. So for patients who have low testosterone, sometimes I can even prescribe them under their insurance policy, because if you prescribe it only for sex, some insurance company will not cover. But remember, testosterone is not just for sex. It's an important one for sex, but not the only one. And the commonest one that I use nowadays is ANDROGEL. It's a gel, it's a cream which you put on your shoulder and it's absorbed. It is supplementation, is not replacement. That means we just improve the level of the testosterone, hoping that the body will be able to produce more testosterone in future following other therapy. For example, if they exercise, they have a good diet, they can stimulate the body to produce more of its own hormones. Of course, extremes of exercise is also not good for health as well. Cycling is the only exercise that can be damaging to the nerve and the vessels to the penis, especially you're cycling on a very hard cycle pillow. Now, in Malaysia and like in many Asian countries, we have a lot of traditional treatment. In Malaysia, the famous one is called Tongkat Ali. In Sarawak, we have Gambia Sarawak. For the Chinese, they have all kinds of products from the tiger penis, and things like that. When in my younger days, I used to say that these medications are quite useless, but now I'm a little bit different. And what I tell my patients is that there are no double-blind, placebo-controlled studies on most of the traditional therapy. So therefore, I cannot say that this particular product work or don't work. I suspect if you take it in moderation, you probably have some beneficial effect to encourage your own body to produce more of its hormones. Now, what about pregnancy after urinary or bowel diversion? I think if the uterus and the ovaries are intact, or especially the uterus is intact, there's no strong contraindication to pregnancy, except that these are high-risk pregnancies. They have to be followed up closely, and preferably should be delivered in the hospital. For men who has surgery to the pelvis, or for men who undergo radiotherapy or chemotherapy, radiotherapy to the pelvis or chemotherapy, it often affects their sperm production. And so they may prefer to go for sperm banking before the chemotherapy or before the radical surgery. If the testes are preserved, but the ejaculative process or the erection process is damaged, we can still go and harvest the sperm from the testes. This is me doing an operation. We harvest the sperm from the testes, give it to an embryologist. The embryologist look for one good sperm and inject it into the egg. And they produce what is called an ICSI baby, or intracytoplasmic sperm injection baby. Is a form of test tube baby. Another big problem in the management of sexual dysfunction is that of privacy. People don't like to talk about this. And in most government hospitals, it is already overcrowded. This is a typical consultation room in a general hospital where there are 3 tables there are three to five doctors with 6 to 10 patients. So actually very difficult to have a consultation regarding sexual dysfunction because it's something very personal. So how do we encourage the patient to come forward? I think medical staff have to make arrangements to actively ask the patient or use leaflets, and we screen for sexual dysfunction in high-risk groups. High risk includes colorectal surgery, especially if they have diabetes, and we should have more sexual education at all levels, including at schools. So I'm coming to my summary slide, that if you have sexual dysfunction, or I think any form of disease, the first thing is the prevention, to go for the modifiable risk factors, the causes, and then we give them counseling, we give them education, and if needed, we give them medications, unless it's contraindicated or if they have side effects from the medications. And if they're still unresolved, then we go for local invasive therapy, like devices, like injection therapy. And finally, we have surgical therapy for sexual dysfunction. So thank you for your attention. I'm most happy to have some feedback either now or at the end of this 1 hour, or you can send to me by email or by WhatsApp, and we can have further discussion. Thank you for your attention.